A common complication in the dialysis unit is low BP. Today, in the context of CKD maintenance hemodialysis patient, we are discussing. Not a single episode. For example, patient comes, BP drops, it reverts back. That cause many of the medicine resident knows. But a constant low BP over a period of 15 days, BP is low. How to approach? What are the causes? The most common cause, by the time if you are following the channel or if you are in the dialysis unit, you might be knowing it is the wrong ultrafiltrate. Patient might be removed excessive ultrafiltrate. Why this can happen? Sometimes we do get a call. They will say, sir, weight gain is not there. But if weight gain, yes, dialysis technologist can follow up with. But as a medico, you should know weight gain is not a constant one. For example, a patient might be having a good diet, good protein diet, because of which muscle mass is building. Nowadays, you can see in Instagram stories where a dialysis patient is going to gym, they are going for swimming, even national level sports are happening for a dialysis patient. So they might be building the muscle, water accumulation is less, but you are constantly keeping the same weight and you are removing the water, patient is going for hypotension. That is one. Another one is patient this diet change. This is two, which is all related to ultrafiltrate. But what if it is not ultrafiltrate? What are the other causes? How to approach? The second most common cause is pericardial effusion. Definitely, if you see 10 cases of hypotension, minimum 3 to 4 will be pericardial effusion. Definitely, fluid might have accumulated. Pleural effusion, unexplained pleural effusion is one of the important cause. Third one, subtle infection in the body, anywhere. Lymph node, probably a tubercular, abdominal infection, abdominal abscess, which might not be showing in the TLC. So these are all the three important causes of hypotension. Another one is in some unaware patient, a high dose of antihypertensive medication, but it right at the beginning only, even a dialysis medical officer might have checked it. Whenever low BP comes, even a dialysis technologist will tell, stop taking that particular drug. So how to approach this case? Whenever you encounter a constant low BP, review the last 1 to 2 weeks or 2 months of weight and what is the ultrafiltrate, what is the trend, how he is spending non-dialysis days. That will give you an overall idea about the ultrafiltrate. That have to be adjusted. The second one is complete blood examination along with liver function test, along with KFT, along with other hepatitis B, C, HIV, you have to get chest X-ray and 2D echo is a must. Along with that, we always get CCT chest plus abdomen. If I say 10 cases, if 3 to 4 is you are picking the pericardial effusion, rest unexplained case. Why I am saying unexplained? Because we are in the tertiary care center, we always encounter, because in the pyramid, the final cases will always come to us. We have to proceed with CCT chest plus abdomen. Most of the time, there the final diagnosis will be made. It is usually a TB or unexplained subtle infection. This is the most common cause. If after this also BP is low, then you can bring in midodrine. Alpha agonist you can bring in, ask them to take a low salt diet, and you can adjust the sodium parameter, which are of at the probably a nephrologist level. It might not be required for the medicine level. Probably at least you should know the basic investigation which are to be done and when to label as unexplained. If CECT, no pericardial effusion, no subtle infection, diet is good, ultrafiltrate is not that much removed from the patient. If bioimpedance machine is there, dry weight can be checked. I hope the residents over here might not be aware what is bioimpedance machine. Bioimpedance machine is the machine which gives the exact value of the patient lean body mass. That, and for that also there is a video. What is that machine? You can see these are the steps. CECT, 2D echo, chest X-ray, basic investigation, treat infection, give alpha agonist. Mostly patient will get normal. If not, finally we will come to the parameters, which is the extreme rare scenario. Before that you will handle. Now we are having one patient who is having a subtle infection. In OPD few patient we handle who was having some kind of chronic TB only. Very rarely a high outflow AV fistula causes hypotension, because there is a very high outflow in the AV fistula. artery to venous flow is very high, BP goes low, which are on the extreme corner. So approach wise you should know all this. Bye-bye.